Okay, we'll get started. Welcome, everybody. My name is Tom Stanton. I'm the president of a Chicago-based nonprofit called the Danny Did Foundation. Here with my colleague Katie Gaughan, who's going to join me in presenting today as well. We're here to talk about two topics that are kind of our points of focus at Danny Did, which are the risk of SUDEP, which I'll tell you more about how it impacted my family, and the category of epilepsy technology, so devices that can monitor for seizures. But we're excited to be here. This is the 10th year. We've been here since year one. We're a partner to this event and grateful that you all made the trip, some close, some far, but we know it's not easy, so we're glad that you're here. So I'm going to start out just by telling you a little bit about my nephew, Danny. You can see him here on the left. So Danny was the third of four kids. He had an older sister, Mary Grace, older brother, John, and a younger brother, Tommy. They were all 2 years apart. So he loved running around with them. He was an athletic, kind of fun-loving little kid, and just loved spending time with his siblings. Danny had his first seizure when he was 2. He had it while he was sleeping, and over the course of the next 2.5 years, he had 4 more seizures that his parents witnessed, always during sleep. After the second seizure, he was diagnosed with epilepsy and put on medication, a journey that a lot of you guys know firsthand. But he was pretty well controlled as seizures go. Like I said, he only had 4 seizures over the course of about 2.5 years that his parents witnessed. So just a few months before his 5th birthday, he had gone to the doctor for just a routine checkup with his neurologist. They had adjusted his medication slightly due to his weight gain, and they left there feeling really positive, really hopeful that they were on the right path. And then it was 4 days later, in December of 2009, that his mom found him in bed on a Saturday morning, and this mad dash to revive him and to bring him back, but he had been lost that morning. And the first time they heard the term SUDEP was actually on his death certificate. So it's not something that they had ever been counseled about or educated. Here's something that's possible. When you think about other disease states, there's a diagnosis, and oftentimes there's a range of things that can happen, and you're educated about the spectrum. In their case, they had never heard of SUDEP before Danny passed away. So the reason that my brother Mike and his wife Mary Ann started the foundation was to try to avoid that scenario for other families, to fill some of the gaps in education and communication that were lacking when they were treating Danny. And people oftentimes ask us about the name of our foundation and where that came from. The name of the Danny Did Foundation came from the last line of Danny's obituary, which my brother wrote, and it read, "Please go and enjoy your life, Danny did." And so while we have this tragedy that was the genesis for why we started, we kind of try to always lead with Danny's spirit and the joy with which he went about his life as a way to project ourselves out into the world. And that's now what Danny is. He is the Danny Did Foundation. It's his new place in our world and how we carry him forward. And we have kind of 2 main goals with how we exist in the epilepsy community. I know you're seeing and hearing about a lot of great resources in this community, and we have a very specific niche, and that is to try to advance and improve communication around some of the risks that come with epilepsy, and also to try to educate families about some of the technology in this space. And we do that with the thought that it can be a complement, not a complication, but a complement to medicine or surgery or diet or the different types of therapy options that people put into place for their loved one. So next, I want to just play a short video that helps to give you a visual on the work that we do.
A journey often begins one step at a time. There is adversity, there is success. There is hope of achieving a goal. The fight to combat epilepsy is a never-ending journey. It is a journey that began many years ago for the Stanton family.
Daniel George Stanton, he's the third of our 4 kids. March 2nd would be his 17th birthday. He might be a baseball player, guitar player, might be an artist. But he'd be one of you guys.
Danny lost his life to sudden unexpected death in epilepsy, or SUDEP, when he was just 4 years old. It is Danny's spirit that guides the Foundation's core purpose, protecting people with epilepsy now. It begins by educating the next generation through programs like our Danny Did Student Ambassadors and partnerships like the Highland Park High School Charity Drive.
It could be anybody in here who learn about Danny, about epilepsy, and who go through life and they become interested in neurology and epilepsy. And it could be anyone in here who takes that path, kind of solves the riddle, cracks the code.
I feel connected to the people at Danny Did, and I think it would be very important to help them out, knowing that there's a community of people who do need help.
The awareness isn't where it needs to be, and so it's super cool that we as a school have the opportunity to provide more awareness.
The epilepsy journey is unfortunately common. Worldwide, 65 million people are impacted by epilepsy, and in the U.S., nearly 4 million people are affected. Today, 1 in 26 Americans will develop epilepsy. My name is Hadley Cronin. I'm 19 years old, and my epilepsy journey began when I suffered my first seizure at the age of 15.
No one in my family had had epilepsy, didn't know anything about it. The biggest thing I remember was feeling extremely alone.
The Danny Did Foundation has been a trusted partner to me as I battle this disease, providing resources that allowed me to attend an epilepsy conference and to purchase a seizure detection device.
There was always that question when I woke up before I had that monitor is, did I have a seizure in my sleep? Now that I have the independence I do, I can make life choices that I know will keep me safe.
As much as it is about raising money, it's about engaging others, it's about spreading the message, and it's about helping to find ways to keep kids alive. I believe there's not a word in the English language for a person who's lost a child, and I don't think there should be.
Oftentimes, life's journey is determined not by the path you choose, but by the path that chooses you. With our growing team and strengthened connection to the next generation, there is no limit on what we can achieve together.
That artwork was done by one of our associate board members, and one of the ways we try to, work into the general public is by having obviously a board of directors, an associate board, family ambassadors program, and we really think that just trying to reach the general public will instigate more momentum for our epilepsy community, because the reality is that most people will cross paths with someone who have had a seizure or who've been diagnosed with epilepsy, and we really need to get them galvanized and caring more about this community that's here today. But we think about epilepsy, you guys all know these risks that are up here, and most of them are discussed at some point or another between a doctor or a nurse and the family. The one that affected our family, like I said, is SUDEP. And a lot of people, how many people here have heard the term SUDEP before at some point? So it may have come from your doctor, it may have come from a friend or another family or an experience. But a lot of people first heard the term SUDEP when an actor, a Disney actor by the name of Cameron Boyce passed away in 2019. And that's when we got the most questions we've ever had in our 12 and a half years as a foundation. What is this about? What is epilepsy? And unfortunately, it took the loss of this young man to really increase public awareness about the risk of SUDEP. When you think about what is SUDEP, the classic definition is a death that is referred to as SUDEP when a seemingly healthy person with epilepsy dies unexpectedly and no clear reason for the death can be determined. And typically there's an autopsy required to make sure that this is a case of SUDEP. There are some criteria that are looked at and required to determine if it's a SUDEP. So number one, the person had epilepsy. The person died unexpectedly while in a reasonable state of health. So in many scenarios, like with my nephew, he was sleeping when he passed. The death occurred suddenly and during normal activity, often during sleep. An obvious medical cause of death could not be determined at autopsy. And the final criteria is that the death was not a result of status epilepticus or prolonged seizures. So think about SUDEP. Why does it happen and how often does it happen? In most cases of SUDEP, the death is not witnessed. Oftentimes, like with my nephew, the person is found in bed in the morning, and the precise reasons about why a case of SUDEP happens are still being researched. And that's one of the most frustrating things about SUDEP is that we still don't know exactly why it happens. I think certain mechanisms are becoming more clear, but it's not totally known. And I think within epilepsy, there's a frustration, at least a lot of the families we talk to, is uncertainty. When is the next seizure going to happen? I think with SUDEP, for us at least as a family, is why did it happen? And what can we do to help prevent it? But there are some theories that exist. One is just cerebral shutdown. The brain is shut off after a seizure, and that the breathing is suppressed due to that. So this lack of respiration being a primary cause. Another theory is cardiac abnormalities. The idea that the seizure can cause a dangerous heart rhythm or even heart failure. And then I think, the possibility and the likelihood that SUDEP may result from more than one cause or a combination of causes, and that the mechanisms might be slightly different in each person that experiences it. In terms of incidence or how often it happens, the most widely accepted research is that about 1 in 1,000 people who are diagnosed with epilepsy will pass away from SUDEP in a given year. And that applies to both children and adults. For people whose seizures are uncontrolled, the numbers are believed to increase dramatically to about 1 in 150 people. So the takeaway being how critical seizure control really is. And I should mention too, we'll have time for Q&A at the end. So if there's any questions you have or comments, we definitely want to welcome those at the end. Risk factors for SUDEP. So uncontrolled, regular tonic-clonic seizures at night present two of the greatest risk factors for SUDEP. So people who are in either or both of those categories, a high volume of seizures or convulsive seizures that happen during sleep, are at the highest risk. And as I mentioned, Danny fell into the latter category. Other risk factors that are being looked at include epilepsy beginning at an early age, having epilepsy for a long period of time, not taking medications regularly or as prescribed, stopping or changing medications suddenly, and drinking alcohol. So one of our huge talking points is just everything has to come from communication. So the idea that disclosing this risk to the caregivers and patients in our community has to be the starting point. And while we at Danny do disclose this risk on a regular basis, We definitely acknowledge that it would be so much better and more meaningful if this communication came from a doctor to a caregiver or a doctor to an adult patient. It just builds trust, it builds an open dialogue that will benefit the treatment in a lot of different ways. One thing we always mentioned was that in 2017, the American Academy of Neurology and the American Epilepsy Society passed the first ever practice guideline about SUDEP. So for the first time, they acknowledged and essentially said that all patients should be counseled about this risk. So that was a big deal because previously, if there was any advice to counsel patients, it was typically for only those who were at very high risk. And now the recommendation or the guideline says that all patients should be counseled. And that was significant. It hasn't turned out to kind of fix the communication problem, but it's one piece to the puzzle. And you think about these bullets and just the idea that we as providers can only really address the risks that we're aware of. So, and the overwhelming majority of caregivers have expressed a desire to know about SUDEP. I'll speak more about that on this next slide. Earlier this year, the Danny Did Foundation was a partner to an effort at Duke University to put out a caregiver study that really examined what do parents and caregivers and adult patients want to know about the risk of epilepsy mortality. And a total of 212 respondents took part, and of those 212, 12 of them had lost a loved one to epilepsy. But the overwhelming takeaway was that caregivers want to receive information about SUDEP from their healthcare provider, but that they typically hear about it elsewhere. So on this slide, you can see kind of the disparity between what caregivers desire but versus the current standard of care. And in open-ended responses to the survey, caregivers highlighted the value of learning about SUDEP from their doctor, the importance of pairing SUDEP risk disclosure with a discussion with how to reduce the risk, and also the need for educational resources and peer support. So these findings really kind of highlighted the urgent need for interventions to improve SUDEP communication. And so we kind of knew this from our 12 and a half years at Danny Did, hearing it from families, but this is another way to kind of validate what parents want and what they're receiving or not receiving. So I always say there's no 100% prevention tactic for SUDEP, but it really has to start with communication that this exists. It's a hard conversation to have. It's a hard thing for parents or siblings or family members to think about, but it really does stem from having that conversation. So once you do have the conversation, the next thing is how do we minimize the risk? What can we do? And the first thing on this slide is kind of what I just alluded to, is just having the conversation in itself, having that communication. The other things that we advocate for is just increased awareness by the public that epilepsy is a serious disease. It's a serious condition. And so we do that through billboards, we do that through radio spots, television. We have messaging in a lot of different airports across the U.S. And the idea is just to put it into the public consciousness that epilepsy is not just some harmless random seizure that occurs here and there for people. It disrupts lives sometimes daily. If not daily, let's say you have one breakthrough seizure a year, it's the uncertainty that really can be scary and disruptive. But beyond all of that, unfortunately, there is this risk of sudden death. And that is something that a lot of people don't know about, don't understand. So we're trying to help change that. Other mechanisms to try to help reduce the risk, we talk about just lifestyle habits that reduce stress and seizure activity, regular doctor visits if seizures are not controlled. And that sounds really obvious, but there are a lot of families that struggle with access, getting to a doctor. Certainly getting to a specialist can be challenging, a level 3 or a level 4 epilepsy center. So that's something that we really try to advocate for. Telling people there are specialists called epileptologists that treat only epilepsy. Some people don't have any idea that there are specialists within our field. So just sharing that basic information can be meaningful. Ensuring that family members and caretakers have knowledge of seizure first aid and emergency resuscitation measures. And then us as a community advocating for research that can help enable a better understanding of what causes SUDEP. I think so much of research is driven by the parent and patient community, and so for us to be actively involved in pushing that forward is really important. And then the last thing I'll mention is kind of what we focus on at Danny Did, and that is the use of monitoring devices that detect certain seizures and can alert caregivers and enable early intervention. So that's really kind of what our wheelhouse is at Danny Did. And so for these next few slides, I'm going to turn it over to Katie to talk more about that.
Thank you, Tom, and thank you to all of you for being here with us. As Tom said, my name is Katie. I joined the Danny Did team full-time in February. I've been on the associate board for many years. Just quickly, why I'm here and why I'm part of the Danny Did Foundation. I grew up next door to the Stanton family, and I knew Danny and got to play with him and his siblings growing up, and they quickly became family. So I'm very privileged, one, to be here with you today, but two, to be working for Danny's foundation. So thank you again for being with us. So technology within epilepsy is fast growing, as I'm sure you guys are well aware. Even just walking around here today in the exhibit hall, you see things are always coming on to this community. We consider devices, as Tom said, to be a complement to medication, to surgery, to diet, as part of a patient's treatment plan. So on this slide, you can see that some of the reasons we feel that the devices can be a benefit for families are, one, as Tom just talked about, parents and caregivers want to use them. They want the conversation and they want this monitoring to be done in their home. We view devices to be another tool in the toolkit. A device doesn't replace a parent's instincts or vigilance, but a monitoring and alerting system can be a piece of that puzzle, an added layer of support for the family that will notify if a seizure is taking place. Monitoring of seizures within a hospital is incredibly important, as I'm sure many of you are very familiar. We would never leave a patient in a room in a hospital unmonitored. But when a patient leaves the hospital and goes home, then what? Monitoring is just as important at home. We feel strongly with the simple concept of early intervention that Tom touched on a few times. If you're present, you can take action, and then you have a chance to intervene and to make a difference. So in this slide, we'll talk briefly about the benefits to the healthcare provider, which is also important. Communication, as Tom already talked about, is wildly important, and communicating about what you're seeing at home is important. It's engaging patients in their own care, engaging in what's happening in the home, and helping facilitate hard or tough conversations sometimes when you're trying to describe what you see at home. Devices prompt timely intervention. We can provide more accurate data, which ultimately, as we know, helps in diagnosis and treatment and ongoing care of your loved one and your patients. The management and treatment of epilepsy are mainly guided by the assessment of a seizure, reoccurrence, frequency, but self-reporting and patient recall is known to be unreliable. In that moment, there's a lot happening, as you guys are well aware. So these devices can be an assistant to you. It's not easy to stay current on all the ever-growing devices that are out there, the technology that is being presented. The marketplace and the pipeline is always changing. This is an area where Danny Did can be a resource. Our role is to not recommend or to endorse a specific product, but simply let parents and caregivers know what the options are. before picking a specific device system, it's important to go through a checklist of practical, common sense questions and considerations. Feel free to stop by our table. We have brochures and things about questions to ask, things to look up when you're looking at a device, but also, again, facilitating that conversation with your healthcare provider. So number one, determine the best method of detection. Think about the seizure types that you're trying to monitor, and consider what type of alerting you want to that as well. Take a look at whether the device can detect the specific seizure type when monitoring. Different seizure types will require a different type of monitoring potentially. Number two, what's the goal of the device? Do you want to be notified if a seizure occurs, and or are you looking to track the occurrence of a seizure? Number three, consider the comfort and relevance of the device. No device will be effective if it's not used correctly. Consider, will it be physically comfortable to wear? Is the child emotionally comfortable to use it? Are there age requirements or weight requirements? Things like that to be thinking about when looking at these different devices. And then, of course, determine the ease of use and the setup. You don't want to bring something home that is wildly complicated that you're just going to add to the stress. So look at understanding what's required of the device. Are other technologies needed? Do you need internet access? Do you need other devices such as a watch or different technologies that will come together with your monitoring system? And then lastly, of course, determine the cost of the device. Monitoring devices can have multiple costs, and that kind of goes back to that last one. Are there other pieces that you need along with it? Internet, watch, phone, that types of things. So what's the cost to purchase the device? Are there monthly fees or an annual subscription that you need to remember to renew? Are there setup and maintenance costs right at the beginning? And then is the device covered by insurance or any sort of medical expenses account? So those are things to all consider when looking at a device. So within epilepsy technology, there's a range of device types. Some of them are implanted and involve surgery. For example, the VNS technology, which features an implantation into the chest, or the RNS technology that features an implant into the skull. These types of treatments are typically reserved for patients with refractory or uncontrolled epilepsy. Invasive procedures, especially for kids, can be a hard decision for parents. And so sometimes the first step is to look into a device that isn't invasive. It's something that can be worn or used at night. So everyone in the room knows the vulnerability of seizures during sleep. There are mattress sensors, video-based monitoring for nocturnal use. For people facing seizures, nighttime can be a scary time, and an alerting device can provide that added layer of support and a little, like we talked about, that extra tool in your toolkit. For individuals with seizures at any time of the day, a wearable option might be the best option. There are wristwatch-based sensors, as well as mobile apps that will connect to an Apple Watch or an Android watch. These devices can allow individuals to have some independence, to go to school, to go to work, to just go outside and play with your friends, and have a little sense of comfort knowing that someone will be alerted and can come to your aid if a seizure were to occur. Early intervention is so important during a seizure. Depending on the individual, intervention may look different, but no one should ever seize alone. When someone is alerted to a seizure, they can take the necessary steps to keep their loved one safe, including providing rescue medication if necessary. Again, these devices complement a patient's medication and treatment plan that's already been put into place. Danny Did works directly with families and not companies. We do not sell these devices. We don't warrant or produce them. We just want to ensure that families are getting all the information and have the knowledge and the power to have the conversation and to start looking for a device that's going to work for them. We're next going to talk briefly through some of the non-invasive device systems that are available now. This is not going to include the implantation options of the VNS or the RNS. This list is not exhaustive, and there's plenty more in development as well. Maybe. So the first one that we're going to talk about is the Embrace 2 watch. You may have heard of this one. It is a watch device that connects to the patient or wearer's phone. And when it detects seizure movement, it will send a signal to that person's phone, and then it will send an alert via a text or a phone call to people who can then respond and check in on that individual. In 2018, the device was cleared by the FDA for seizure monitoring and to detect seizure events that may be generalized tonic-clonic seizures. The Embrace measures more than movement. It measures more than a dozen parameters, deriving from patterns not only from movement, but other physiological changes that come with a seizure. So a key point for the system is that it is validated at actually detecting seizure events, not just movement events. Our next slide here is going to talk about the smartwatch Inspire. This is an app that will connect to an Apple or Android watch. It will detect that rhythmic shaking motion of a convulsive seizure. And again, it will send an alert to that person's phone, and then that will send out a signal via text or phone call to as many people as you're choosing. And now that kind of goes along with which subscription you go with. So that calls back to some of the questions that we looked at. Are there other costs associated as far as subscriptions go? Yeah. Our next one is the MFit movement monitor. This is a nocturnal monitoring device that is placed under the mattress and can detect movement. Once movement is detected, an alarm will sound in the room so that a family member can then come and check in on that individual. The MFit QS is an app that collects data during sleep. It's not an alerting device. Some families will use this in tandem with the MFit movement monitor. And then this is the SAMI. It's a sleep activity monitor for caregivers who need to watch for abnormal movement at night. During sleep, audio, video monitoring, and information from a remote infrared camera. So it's a little bit like, if I can make the correlation to a little bit like a baby monitor, and that has that night vision. You can take a live look in at any point. But when it detects movement, an audible alarm is going to come through an iPod or iPad that you would have either on your nightstand or if you're in the kitchen or your living room. That audible alarm will come through, and then you can go in and check in on your loved one and intervene if need be. A feature of the SAMI is that once the system is triggered, it does begin recording, and then you are able to share those recordings with your physician if you so choose. And then the next one is the MeQ monitor.
Yeah. Go ahead. Yeah.
So I'll just start talking. So the MeQ is another nocturnal monitoring system. Again, similar to the baby monitor model, it is a camera that connects through an app on your phone. Now the MeQ is a little different in that it's monitoring respiratory rate and respiration. So you'll actually see, I think you can see it here, kind of the up and down respirations, and it will alert or alarm through your phone should breathing stop or become very slow and irregular. This product was the winner of the 2021 Shark Tank competition hosted by the Epilepsy Foundation. Trials are underway at Boston Children's to make this technology even more aligned with tracking seizure activity. And then the pulse ox. This is a portable pulse oximeter, a non-invasive medical device that typically attaches to a fingertip or a toe, and it's measuring heart rate and then blood oxygenation. Both vital statistics that are affected while a person is having a seizure. These devices are not designed or manufactured to detect a seizure, but a pulse oximeter, they do have applicable monitoring and alarming sound functions that can be used when a person is experiencing a seizure. One company that is making the portable pulse ox is Massimo, which you can read more about on our website, dannydid.org. And then these devices are sort of the low-tech safety options. Obviously, we talked about monitoring for a seizure and alerting in the event of a seizure. These are some devices that can just help keep your loved one safe during daily activities. So this picture here is the shower belt. And this is a device that hooks up to your shower. So in the event of a seizure, if the person were to fall to the ground, it will automatically turn the shower water off and prevent an instance of drowning. The other one is an anti-suffocation pillow, and then the top one here is showing the harness. If you're interested in more details about these or any of the devices that we just talked through, again, they're all listed on our website, dannydid.org, on our devices page. You can also find webinars called Dissecting Devices. These they're webinars where Danny Did had the opportunity to speak with the manufacturers of these devices. They're a great source of information and answer many questions. They're about 45 minutes to an hour, but super informative and can be very helpful when making a decision.
Okay, thanks, Katie. So yeah, I would make an extra plug for that series we call Dissecting Devices. All of them are archived at dannydid.org, 45 minutes each. You know, watch them. If something perked your ear and you say, hey, that might work for us or that might be a fit, we probably have a webinar about it. So I would definitely encourage you to check those out. This next slide just talks about the limitations of where we're at. So the epilepsy technology space is definitely on the front end. It's not as mature as it will be at one point. So we don't want to pretend like this is a panacea, you know, like this isn't a cover-all. There are shortcomings for sure. Only a few of these devices have FDA approval, which can be a barrier from the standpoint of awareness. So typically what you hear about comes from your doctor. In order for your doctor to talk about it, they probably have to be FDA approved. So there's this trickle-down thing. So getting to that point of FDA approval has been much more challenging for devices in epilepsy than, for example, drugs in epilepsy. So that is something that's evolving. Insurance coverage. So even for those that have achieved FDA approval, they're not reimbursed, and there's a gap that exists in terms of the economics. What can our families afford? And are there ongoing costs that just add to the barriers we're already facing in terms of the cost and the burden of epilepsy economics? So that's really one thing that we try to relieve is to be this bridge of funding for families that have identified something that could be helpful, but they can't afford it. And, you know, we're not the long-term solution or the best solution in terms of the big picture. Ultimately, we need these things to be reimbursed so that these companies can be sustainable and innovating and getting better and stronger and ultimately surviving, sticking around. And then just the idea that, you know, the products that exist right now are not as sophisticated as they will be moving forward. So you may have one device that does a pretty good job of alerting to movement, but, you know, your child's seizures might have multiple indicators of why they're seizing. And can we get systems that are multimodal and alerting to different types of indicators beyond movement and doing so reliably? Obviously, false detections are a huge problem when it comes to systems. We don't want the alerts to be so, the inaccurate alerts to be so common that we get alarm fatigue and we stop responding when there's a alert sounded. That wouldn't be a good outcome. Okay, so we'll talk briefly about what's coming, what's in the future. There are systems in development that will be more sophisticated, hopefully more reliable. Detection for generalized tonic-clonic seizures right now is pretty good, but detecting other types of seizures is the next chapter. So beyond that, looking at like forecasting and prediction systems, it would be even better than saying, hey, a seizure is happening, to say a seizure is about to happen. Maybe you can get into a safe place if you're driving, for example, or if someone's notified a seizure is going to happen during sleep. Maybe there could be intervention before the seizure actually happens. But ultimately, prediction and getting to that point of where a system could deliver some kind of intervention to suppress the seizure would be kind of our holy grail. Say something's about to happen, now we're going to deliver a treatment to stop it from happening. That would be kind of our ultimate dream when we think about Epilepsy Foundation or epilepsy technology. Okay, and then the last challenge pardon me, I lost my spot here. I think, Katie, I'm going to turn it back to you to talk about some of our resources to getting these systems for families.
Yeah. So many families come to Danny Did for resources, help facilitating conversations and asking questions, as we talked through already. And sometimes the conversations end there with information and education. However, because most seizure detection devices are not covered by insurance, that's kind of where Danny Did can step in, and families can come to us if finances are a barrier to getting a seizure detection device into their home. They can come to us and apply for grant funding to purchase a detection device. So after a family decides on what device might work best for them, you can apply to Danny Did, and I will reach out to set up a phone call, and then we will chat on the phone and move through an interview process, and I help facilitate that, and then help move through the process. And then if the grant is approved, we provide the funding directly to you and to the families to make your purchase. We do our best to keep in touch with every family and continue to be a source of information and a source of friendship. But we are here to really help families learn about the devices, but also get them in place in their home. I'd love to chat more with you about it, and I'll be over at the Danny Did table. We have plenty of brochures that look like this in both English and Spanish, and talk about the steps to applying for a grant. So come on over and chat with us about that.
So we're a small foundation. We're based in Chicago. We've got a small team, but we have a lot of partnerships that help us kind of reach more people in places. One of them is called Partners Against Mortality in Epilepsy, or PAMI. And we are one of the kind of planning leaders among nonprofits for this conference. So I just want to make a plug to say that it's coming up in Nashville on November 30th and December 1st. So the focus here is to bring together advocates, scientists, researchers, clinicians, industry partners, and most of all, families. So families maybe have someone living with epilepsy, and there are a lot of families there that have lost someone to epilepsy, either through SUDEP or another form of epilepsy mortality. And the idea is just to learn from each other, to share the latest on research and advocacy, and trying to move forward to a future where epilepsy mortality isn't such a burden on our community. So if anybody's interested to learn more about it, go to our website, dannydid.org. Again, that's coming up in just a few weeks. If anybody's interested to get more involved with our foundation, we welcome that. We have a bunch of different ways to do it. Pardon me. Here we go. we have something that we call Team Danny Did, where folks will run marathons, triathlons, bike rides, anything they want to do to raise awareness and funds for our cause. We have an ambassador program. We're lucky to have several of our ambassadors here. You could do everything from hosting a table at a conference to going to speak at a school, hosting a walk or some kind of fundraiser event. Anything that kind of is close to your heart in your community that can help to further epilepsy awareness and awareness of our work at Danny Did. So if you're interested in something like that, our website is a great place to start. And beyond that, just know that we're here today. We'll be with you tomorrow. But beyond that, we're accessible. We try to be very available. We're parents. We're family members, just like you guys, and we talk kind of parent to parent. So if we can be helpful to you or people that you know moving forward, reach out anytime, and we love to connect. And with that, I think we'll open it up to any questions or comments. Yeah.
Which devices have you seen specifically covered by insurance?
So that's a good question. The question was, which devices have you seen covered by insurance? It's been really sporadic. Even, I'll use the Embrace as an example, very little coverage. There was a system called Speak by a company called Brain Sentinel that also received FDA approval as a diagnostic tool. They're no longer under the umbrella of Brain Sentinel. There was some reimbursement for that. But honestly, the stories that we've heard for approval have come down to like just super nurses that find a code and kind of work it through the system. And it hasn't been predictable or something that can be necessarily replicated on a wider scale. So that is a priority for us as advocates, is to figure out how can we get these devices more consistently covered by insurance, because we're just a bridge in time. We need this to be sustainable, like other disease states have resources that are covered. So unfortunately, I don't have a great answer. Yeah.
So, SUDEP, is it something like SIDS where they really just don't wake up? Or is SUDEP, could that be something where they maybe had a seizure in their sleep and suffocated? Or is it more like SIDS where they just don't?
Yeah, that's a good question. So just asking about the analogy between SIDS and SUDEP. Are they similar in that the person just passes away kind of without explanation? And it's more like the latter. So certainly you could have a seizure in your sleep and suffocate in your pillow. And that's hopefully where a resource like the anti-suffocation pillow could be helpful. But that wouldn't necessarily be considered a case of SUDEP. SUDEP is really this category of exclusion where you don't know what happened or why, and now you're putting it into this category of sudden unexpected death in epilepsy. But there is, from a communication and awareness standpoint, we talk a lot about SIDS and the campaign that a lot of us heard about, years ago, Back to Sleep, and how that kind of became mainstream and known. And even if you weren't personally impacted by a case of SIDS, you knew some of the messaging around it. And I think that's kind of one model we can use. There's also an organization called Sudden Unexpected Death in Childhood, or SUDEP. And they're a foundation based in New Jersey. It's believed that maybe some of those cases are cases of SUDEP that their families experience, and they just maybe never had a diagnosis of epilepsy or never witnessed seizures, but they were happening in sleep. So there are some unknowns, but it is believed that in most cases of SUDEP, a seizure happens. That's not to say that there haven't been cases of SUDEP where there was no seizure, but it's believed typically there's a seizure that happens.
You also mentioned that the more frequency of seizures that the person has, the higher the likelihood of SUDEP. Cameron Boyce, I had read, had only had a total of like 5 seizures his whole life, similar to your nephew. and his was SUDEP, right?
Yeah, his family found out about SUDEP after the fact, like ours did. They had not heard of the risk. And so I think that's an important point when we think about messaging and sharing information with parents. It really can't be with just any one audience. Certainly there are syndromes within our epilepsy community that are more impacted by SUDEP than others. They have more cases than others, and they need to hear about it. But so do the Boyces, and so does Danny's family. And we advocate that it be done in the context of safety. So when you're going to talk about other risks that come with epilepsy, that's the opportunity to talk about SUDEP. And if it jumps off the page and people have questions, then certainly you can have a dedicated conversation that's more in depth, and hopefully the doctor has good information about, how to try to reduce your risk. But our point is just don't leave it out altogether. It's really something that needs to be communicated in some form or another. So I would just thank everybody for being here. I know this isn't an easy topic or an easy conversation, but we do this in memory of Danny and all the lives, too many that have been lost, and in hopes of preventing that in the future. So if we can ever be helpful, stop by our table or reach out, and we'd love to keep in touch. Thank you.
Thank you.